So we're going to talk today about splenic reduction, when and how. So this was actually a workshop I did at SIR this year. So this talk is from my workshop there. So there are two parts of this lecture. There will be a small didactic, and then I'll show you cases to illustrate exactly what I showed in the didactic. So let's begin. So we'll be talking to you about the indications. When do we need to do splenic reduction? What all the technical considerations you need to know before you do it. We'll talk a little bit about the outcomes, what to expect. Complications are always there, and then some controversies regarding splenic reduction. So what exactly does splenic reduction mean? So splenic reduction means basically to decrease the size of the spleen in layman's language, okay? Before you talk about anything about splenic reduction, we need to know the anatomy of the spleen. So like anything in radiology, if you do not know the anatomy, you cannot make a diagnosis. Similarly in IR, if you do not know the anatomy, you cannot do a procedure. So splenic artery normally arises from the celiac artery. It normally divides into superior and inferior branches, and then these divide into 4 to 6 segmental branches, okay? The inferior polar artery gives rise to the left gastroepiploic artery. Where does the right gastroepiploic artery arise from? GDA. So you need to know this because these are the collateral pathways. Collateral pathways are important because even after doing splenic reduction, the spleen stays alive. If you do not know these, you will not be able to treat that. Short gastric branches arise from the terminal splenic or left gastroepiploic artery, and they supply the terminal part of the spleen. Very important, splenic artery supplies the pancreatic body and the tail. So the dorsal pancreatic artery and the greater pancreatic artery, or the arteria pancreatica magna. So these are two important arteries. The dorsal pancreatic artery is the most important artery. If you have to sacrifice any other artery, you can, but do not embolize the dorsal pancreatic artery. Otherwise, patient will have pancreatitis. Okay. Where all does the dorsal pancreatic artery come from? It can come from the splenic artery. Where else? It can arise from the celiac axis. Rarely it can arise from the hepatic artery. So it supplies more of the head and body. The greater pancreatic artery, or the magna, actually supplies more of the tail. So collaterals. So how can we safely embolize the splenic artery and yet the spleen stays alive, right? Because of these collaterals. The left gastric artery, which is a branch of the celiac artery, through the short gastric arteries can supply the spleen. So on Friday, I actually embolized the two main branches of the splenic artery, and yet the spleen is being perfused by these collaterals. The right gastroepiploic artery can communicate with the left gastroepiploic and supply the spleen. So this is the second collateral. The pancreatic arteries from the GDA, SMA, and splenic artery through the transverse pancreatic artery can supply the spleen. This is the third collateral. And then you can have omental branches supplying the spleen. So there are a lot of collaterals. So if you embolize the main splenic artery, there are other collaterals to keep the spleen alive. So this is where it shows you the anatomy, right? So the celiac, splenic, hepatic, there is the left gastric here. This is the GDA, which continues as the, what is the GDA, what is this branch? Right gastroepiploic, okay? Here the left gastroepiploic is going to come from here. This main branch is the dorsal pancreatic artery, which is the main supply here. So you can embolize anything distal to it, but never embolize this. And this other major branch is known as the greater pancreatic artery. The short gastrics will come from here. So indications for doing splenic reduction. When do we need to decrease the volume of the spleen? For any cause of hypersplenism, primary or secondary, when you have portal hypertension and you have variceal bleeding, we've seen these cases. Treatment for thrombocytopenia limiting chemotherapy or antiviral therapy. So a lot of times when they used to treat cancer patients, they become thrombocytopenic, and then they limit their therapy. So you can actually embolize a part of the spleen. And antiviral therapy is basically when they used to treat Hep C in old days. So the platelet count used to be a limiting factor. You can treat for splenic hemangiomas. If they have patient has big splenic hemangiomas, you can do splenic reduction. And then splenic artery steal syndrome. This is a very peculiar indication. The steal syndrome actually happens in patients who are actually post-transplant. So what happens is patient gets a transplant but has a big spleen. The liver post-transplant is not doing well because all the blood is going towards the spleen. So you need to decrease the blood flow towards the spleen so that the liver gets more blood supply. So that is known as the steal syndrome. So history. briefly when it was first started. So first time was performed in 1973 by Madison. So what he used was autologous blood clot. So you just let the blood sit for a while on the same patient's blood, it forms clot, and then you inject clot. And then finally in 1983, Spigos actually successfully treated 6 patients with varices using partial splenic embolization. So this is the history behind splenic embolization. This was only one case. This is when the first time it happened, and they did it with antibiotic coverage and post-embolization pain control. And these are the landmark papers for history of splenic embolization. Coming to technique briefly. So you can use any axis. You can use a femoral. You can use a radial, brachial. Commonly we use the femoral axis. You normally place a sheath. You go and access the celiac artery, right? So you can select the celiac artery with a 4 or a 5 French reverse curve catheter if needed. You can do a angiogram to see the anatomy of the celiac artery. Then you identify the branches to the pancreas because you want to avoid those branches to the pancreas. And then nowadays we use actually a microcatheter to go selectively into different branches of the splenic artery to embolize. So there is a concept of proximal versus distal splenic embolization. So proximal splenic artery occlusion, if you occlude the artery proximally, is unsuccessful. Why? Because I told you there are so many collaterals. So if you put a coil there, it does not cause splenic volume reduction because the collaterals will take over and supply the spleen. So, and then there is a concept of proximal versus distal, and there is a concept of selective versus non-selective. Selective means you go to individual branches of the splenic artery to embolize small parts of the parenchyma. Non-selective means you just go to the distal splenic artery, distal to the branches of the pancreas, and you just shower from there. Either you can put gel foam or particles. So you do not have a lot of control. You do not know how much volume of spleen you're being embolized. Normally we embolize using 300 to 500 micron particles and rarely 500 to 700 micron particles. What is normally used is either gel foam and just the ethyl alcohol polymer particles. Recently, a lot of case studies are coming in where they're actually using glue. What they do is actually they go to these selective branches and they glue every alternate branch. So there was a recent paper from Stanford where they did this in patients using glue. So they embolized they choose the branches like this. So you have to embolize like 40-50%. So rather than embolizing every branch, they choose every alternate branch. And they glue one, leave this one, glue this one, leave this one, and they call it the zebra pattern. Looks very fancy. The problem with that is you need a triaxial system, you need to get a sheet there, so a lot of equipment cost, and then glue is very expensive. It's a couple of $1,000s. So for something you can do cheaply, they do it expensive way, but it's done. So during the procedure, you will do intermittent parenchymal phase angiograms to estimate the volume of tissue. A big problem of doing splenic embolization is to estimate how much volume you've embolized. Remember, the spleen is like a reniform shape. It's like a kidney shape, right? So you really you think you've embolized 30%, and times you find you embolized 50%. Sometimes when you think you embolized 50%, you actually have embolized 30%. So during the phases, you keep doing the angiograms to see how much of the spleen you've embolized. There was a paper, this one which is actually came out from Japan, where they devised a way to estimate the amount of splenic volume. What they did was they did angiograms, they measured the size of the main splenic artery, and then they measured the size of each splenic artery branch. And depending on the branch, they calculated how much parenchyma was supplied by that artery, and then they embolized it. But you can imagine how much time they need to measure each and every branch. The easy way to do is do a cone beam CT. So if you're embolizing, you're not sure of the volume, you leave your catheter there and you do an angiogram with a cone beam CT. The cone beam CT will actually tell you approximately how much volume you've embolized. And I'll show you cases for all this. So this is just an example just to show you how we do it. So 61-year-old with portal hypertension, hep C cirrhosis, breast cancer. So she is limiting, her thrombocytopenia is limiting her chemotherapy. She has a huge spleen. So as you can see, there are the 2 branches, and each branch divides into different branches. So you do a splenic angiogram, then you go to each and every branch. This is we went to the lower pole branches, we embolize the lower pole branches. This is during the phase, selective embolization of the inferior pole using 300 to 500 micron particles. This is where you are embolizing these branches, and this is the post. So if you want to see the parenchymal phase, this is the post. So you've only embolized the lower part. So you embolize about 30 to 40% of the spleen. Okay? This is the same patient follow-up. So you see, this is the spleen which is live. This is the portion that we've embolized. This is how it looks on ultrasound. The embolized spleen. Okay? And this is the flow to the spleen. So showing that only a partial spleen was embolized, the platelet count tripled in 2 weeks, and they go back to the chemo. This is the same patient, or not, I'm not sure it's another patient, but this is the cone beam CT. So during the procedure, I was not sure how much I've embolized. So I did a cone beam CT, and then I did this reconstruction. So this clearly shows me how much volume I've embolized. So you can actually estimate from this is during the procedure, how much volume you embolized. Okay. Pre and post procedure care. So they all get broad spectrum antibiotics on the day of procedure. Antibiotics are continued for at least 5 days post procedure. Normally amoxiclav is what we give. There is a concept of giving vaccinations. So when they used to do splenectomy, this is coming from the surgical literature, they used to give patients vaccinations. So either they give them a week before or 2 weeks later after the splenectomy, and they get these 3 vaccinations: a pneumococcal, Haemophilus influenza B, and meningococcal. So these are all encapsulated organisms which actually the spleen protects us from. But of the recent literature coming from IR, if you're embolizing less than 50%, you really do not need to give them. Only time when I will give them is when the patient has other comorbidities. If patient has ascites, has history of SPP, is a sick patient with cirrhosis, then I might give this because their immunity is already low. I might give them also if they are on chemotherapy, because then the immunity is low. You don't want to have them any of these infections. They go home on a Medrol dose pack. This is to decrease inflammation and mitigate post-embolization syndrome. So current controversies. This is where all the literature rise. So which pole to embolize? So you'll see the surgeons in the HBB always saying embolize the upper pole, upper pole. I agree, but there are certain indications when you embolize the upper pole and when you embolize the lower pole. So lower pole is preferred because it is not close to diaphragm. They do not have a reactive pleural effusion. They'll have less pain, less chance of pneumonia. So we always prefer to do the lower pole unless it is for a variceal bleed. Gastric varices arise from the upper pole. So if you're embolizing for gastric varices, then you would go to the upper pole. Otherwise, lower pole is much better. Initial target volume. What is the volume that you want to embolize? So if you embolize 30-40%, you do not get a sustained result. If you embolize 50% to 60%, that is the sweet spot. Problem is if you embolize more than 70%, then all the complications happen there. So everybody varies. So there is these days a conservative approach where we initially embolize 30-40%, see how the result goes. If the results are not sustained, then we can go in and embolize more. But if you've already embolized 70% and caused the patient complication, then you can do nothing about it. So people are moving more and more towards the 40% area and then bringing the patient back to treat more if needed. Outcomes. So whenever you get these cases, you need to talk. They'll also ask you, what do you think is the result going to be if we embolize it? So platelet counts will normally rise in 12 to 24 hours, as soon as 24 hours. They peak in 1 to 2 weeks, and the count stabilize in about 2 months. And then they slowly decrease over several years. So how much do you think you can say platelet? Normally double that figure, what was the base, is very reliable. You can actually have patients triple their counts, but double count is what you really think can happen. The RBC count also increases significantly by 6 months, and also the WBC count increases. So a lot of times you'll get called that these patients sent home were having pain. Somewhere in the hospital they did a count and the WBC count is raised. It is because of the embolization. It is not because of any abscess or anything. It is just a normal phenomena. Decrease portal vein pressure. So it does decrease portal vein pressure. There are studies which have shown that when you do this with ligation, it decreases rebleeding. So in patients who actually cannot get a TIPS for some reason, or have a portal thrombus, or we cannot access the portal vein, you can actually decrease the portal pressure by embolizing a large volume of the spleen, especially the upper pole. Significantly improve portal hypertensive gastropathy, similar indication. Improvement in hepatic encephalopathy. So if a patient is hepatic encephalopathic and you can't do a TIPS, this is one procedure that you can do to prevent him from variceal bleeding and also improve his encephalopathy. And then it increases the liver function. So the thought of this is actually it decreases the flow to the spleen, increases the flow, arterial flow to the liver, and increases liver function. This is exactly what happens in the Steele phenomena. Complications. So every procedure has complications, right? So everybody will probably have a post-embolization syndrome consisting of fever, nausea, left upper quadrant pain, This is going to occur in about 90% patients. So we do tell the patients that you're going to feel bad for a week. This is how it happens. They can have a lot of pulmonary complications, pneumonia, atelectasis, pleural effusion, usually after upper pole. So all these patients are told to have incentive spirometry. When they go to the fore, we tell them to do incentive spirometry to at least so that they can breathe, less atelectasis, less chance of pneumonia.
Do you have them do that even if it's a lower pole?
You would prefer to do that, yeah. So this study looked at, companies looked at 33 studies for patients, and they had serious complications were abscess, large pleural effusion causing dyspnea, ascites, pneumonia, PE, portal vein thrombus, and liver failure. They actually had 4 deaths were reported. So serial complications always occurred when they were 70% more when you embolize more than 70%. So realize if you are embolizing 50%, you'll get away with it. 70% and more is where all the problem comes, and I'll show you these cases. This is another study where they saw about 8 studies, and the rate of complications again increased when they embolize more than 70%. So see this, embolize the upper pole, the ascites. See this, pleural effusion, atelectasis. See this, the whole spleen was embolized, the whole portal vein is thrombosed. Okay. This is a normal phenomenon. If you see this on CT, you see this kind of air, this is post-embolization. Do not worry that this is an abscess. Abscess looks very different. Abscess has it's going to be round. There's going to be areas of kind of air there. This is air in the arterial system, okay? But what you need to realize is this portal thrombus. So in conclusion, partial splenic embolization can be safely performed, keeping the total embolization volume between 50 to 70%. I feel it's going more and more towards the 40%, 40 to 50%. It can be performed alone or in conjunction with other procedures to treat portal hypertension, bleeding varices, as well as to improve blood counts from hypersplenism. So I'm going to show you the cases now so that you can, what you saw can reinforce on all these things. Okay. So case 1, 42-year-old female with cirrhosis, NASH, breast cancer stage 4, similar case to one that you saw, unable to receive further chemotherapy due to low platelets. Carboplatins are known to cause, the platins are cisplatins are known to cause thrombocytopenia. Cisplatins are known to cause, it is related to the dose. When they start their treatment, they do not have thrombocytopenia, but more and more they cause, more and more chemo they get, then the platelet counts fall down. So baseline platelets were around 100,000. Post-chemotherapy platelets always go down to 45,000. So the oncologist actually will stop chemo every time the platelets go below 75. So then she cannot receive any chemo. Had an enlarged spleen on imaging, we were consulted for doing embolizing the spleen. And these all cases are from here, okay? So you see the massively enlarged spleen. You need to take a good anatomy, see where all the arteries are coming from, see where all what is feeding there. So we went super selectively into the spleen, embolized the lower pole, another branch of the lower pole. This is the post. So we embolized about 40-50% of the lower to mid-polar region, interpolar region, spared the upper pole. This is the same cone beam CT for that patient. Okay. So we selectively embolized the inferior pole, splenic artery branches using 300 to 500 micron particles. Shows complete occlusion of the target splenic artery. Cone beam CT to evaluate the volume. Platelets at 1 month post-embolization 180,000. And then she successfully cleared her chemotherapy. So if you raise the baseline from 100 to 180, they will fall again, but they will be okay for them to give the chemotherapy. Okay? And why only embolize 40 to 50%? Because in case they need to do it again, means 6 months later she needs more chemo, you can always go ahead and embolize another part of the spleen and keep the patient on another chemotherapy. Case 2. 54-year-old male, history of hep C, alcoholic cirrhosis, presents with upper GI bleed. GOV1, 2 on endoscopy. He's encephalopathic, so tips will not do good for him. Poorly controlled on lateral rifaximin, still drinking, so you don't want to put a tips on these patients. Platelets are 34,000, bilirubin 2.8, creatinine 1.8, INR 2.1, albumin 2.4. His MELD is about 28. So his 3-month survival is about 70%. He's probably going to pass away in 3 months, and he's encephalopathic. So what do you now? And then he's still drinking. This is him. On top of that, when he got CT done, he has a portal thrombus. So you can't attempt a TIPS on him. He's portal thrombus. This is his spleen. You see the portal thrombus all the way here. You can see the beautiful portal thrombus. This is all portal thrombus. Okay. That's his spleen, ascites. What options do we have for him? So we actually, this is an image showing all the gastric varices, and they're all coming from towards the spleen. This is the same patient. This is the splenic. Here we embolize the upper pole because the varices were coming from the upper pole. We embolize the upper pole. In these cases, I tend to leave a coil back because I want more permanent occlusion. So I will leave a coil in here after embolization. This is his post. You can see that we embolized a decent volume of the upper pole. Vessel bleeding stopped. Platelet at discharge of 60,000. He's still drinking. So this was his follow-up. Case 3. A 60-year-old female with stage 4 metastatic rectal cancer. Chemotherapy again on oxyplatin. Stopped after 4 weeks of cycle due to low platelets. They used to drop to 50,000 from base of 130. This is normal size spleen. So that first case actually had an enlarged spleen. This is a normal size spleen. You can see this. These are the mets, a normal size spleen. Large met here. The spleen is normal size, okay? That had a large spleen. So in these cases also, this is the met. See the large met? See the spleen is normal size, so be careful. When the spleen is large, 40% volume can become a big volume. When the spleen is small, that 40% volume can be a small volume. So be careful when you embolize. It's not only dependent on the percentage you embolize, it also depends on the size of the spleen. So I believe what actually makes a difference is the volume embolized. So here we actually embolize the lower pole, drop some coils. This is post. And actually you see there is a difference here. What has happened to these tumors? They had such a good result from this that they called me back to treat this tumor also. So we treated this first. He got his systemic chemo. Then I came and did chemo embolization for these tumors too. Okay, this is his post. Platelets improved to 180,000 in 3 weeks. Chemotherapy resumed. Patient was referred back to IR for local regional treatment of his liver mets. Case 4. A 54-year-old male with severe ITP, idiopathic thrombocytopenic purpura. So what is the normal treatment for ITP? What happens? Steroids. And the traditional way to do it is actually getting us, they think if any splenic tissue is left, it recurs, so they tell you that take the spleen out. Splenectomy is done next. History of epistaxis and GI bleeds, failed multiple treatment regimes, admitted with a platelet count of 3 to 6,000. That was his platelet count. Normal appearing spleen, suspected cirrhosis of the liver. Because he is so high risk and he had other abdominal surgeries done, surgeons did not want to do a splenectomy on him. So what is left is what we can help him with. This is his spleen. It's not enlarged. ITP normally has enlarged spleen, but for some reason his spleen was not enlarged. So we embolized it. Okay. This is post-embolization. Platelet improved to 40,000 after embolization with minimal medication. For a while, did well. 2016 again slowly declined. Patient on weekly Nplate. This is a very expensive medication. It's about $3,000 a week. So he was getting this, and then his insurance denied. They would not cover him anymore. So IR was consulted again to see what we could do. Remember, he's not a surgical candidate. This is a CT scan. It shows you that he has some sort of a cirrhosis here. This is his initially we had embolized the spleen, remember? This is how it looks, like a scar. Over a period, the spleen regenerates. Like liver regenerates, spleen regenerates. So we had embolized him. See this? We embolized a decent part of it here, right? But on his next scan, it actually looks pretty, it has regrown. So only a little part is embolized. So we thought we can go back and embolize him again. So this is how it looks. So we went in. This is the angiogram. We can see what we embolized, but a lot of part of it has regenerated. We went in and again embolized him. Little more volume this time. Platelets improved to 30 to 40,000 in 1 month with decreased weekly end plate. So we got a good result from him. This is how he left. So he used to stay in this region. See, 3,000, 6,000, and this is how he's done over the period. Case 5. So these are all variations. So when you think about splenic embolization, you think, oh, chemotherapy, ITP. there are different indications, different ways of doing things. So when I was presenting SIR, my thought was to bring in different types of cases for different indications. One of my colleagues was doing different ways to embolize. So I don't have his cases, but this is more of the theme was different indications. So just to broaden that, we don't embolize for one thing, you can do this for a lot of procedures, you can bring it to them. So 21-year-old male with HST. So you guys see HST all the time, right? What do they have? What do HST present with? Epistaxis. What else? When will we see them in IR? Pulmonary AVMs, okay? So a variety of HST can also have giant hemangiomas. So this patient had HST, imaging showed splenomegaly with giant splenic hemangiomas, and in the family there was history of spontaneous splenic rupture in the mother because of these hemangiomas. Right now he's asymptomatic. So we were called in to embolize this. This is his spleen. This is a hemangioma. See, giant hemangioma, another one here. See the size of the spleen. Huge hemangioma. This is his pulmonary AVM. So we embolize the pulmonary AVM. Then we came in to embolize. This is all the hemangioma. See, this doesn't look like a spleen. This looks like a tumor. It's all round. So we actually empirically embolized it. This is not to increase his platelet, but this is to prevent his spleen from rupture, because he has a history of spontaneous rupture there. Okay, currently asymptomatic. Case 6, 44-year-old male, 6 weeks post liver transplant. This is a case from Williston. So they did a transplant. His ALT, AST are raised, right? These are not normal. Billy has not raised, but alpha is raised. So ALT, AST raised post-transplant tells me there's something wrong happening there. Remember I told you about the steel phenomena? So he actually has, this is the celiac angiogram. This is the hepatic. This is post-liver transplant. What you can see is the splenic artery is actually bigger than the hepatic artery. So when the splenic artery is about 1.5 times the hepatic artery, we call it the Steele syndrome. This is what was in this patient. This is his spleen. You see a markedly enlarged spleen. Embolized. This is post-transplant liver. Okay. This is the imaging post. This is post-embolization. 2 weeks post AST and ALT return back to normal. So you can actually do this for a lot of different indications. You just need to realize that you can help a lot of patients through this procedure. Case 7. 55-year-old female with NASH cirrhosis admitted with normal pain and nausea, partial splenic embolization outside hospital 1 week ago. WPCs were 17,000, platelets were 240,000. So I was called in because this patient had a white count of 17,000. They called in for an abscess drainage. That patient is infected. They got a CT scan done. That patient has abscess. So this patient developed ascites. This is the splenic embo, which is normal. But what was worrisome was this. And this patient was supposed to be evaluated for transplant. So when I saw thrombus in the portal vein, not in the intrahepatic portal vein, and I saw this, what they did was they embolized more than 70% volume. See, they embolized a lot of volume here. So it's probably more than 70%. That is why she developed ascites and she developed thrombus of the portal vein. So in these cases, you want to keep the portal vein open for the transplant people. So we actually did a TIPS for her. We went through the normal approach, placed a TIPS stent for her, which is still open, and it's a patent TIPS. Ascites has resolved. This is post-op. This is the spleen, and she's actually been under TIPS. She's evaluation for transplant. She's still waiting for a liver transplant.
You were able to do that because the thrombus was not intrahepatic?
Yeah. You can do it in intrahepatic thrombus also, but the first patient also not only had intrahepatic thrombus, he also had encephalopathy, right? I would have made him worse. On her, it is very important because if the thrombus goes intrahepatic, or if I cannot resolve, this thrombus is resolved, can't resolve this thrombus, she will not be a transplant candidate. And that guy was actively drinking. She's not actively drinking. This is NASH. So it's a different disease. 40-year-old male admitted with variceal bleeding post-banding triple phase liver CT. So in this patient, we were called in to think about a possible TIPS. His portal vein is tiny. He has ascites, and on top of that, he has this lesion in here. Okay. So, and he has gastric varices which are bleeding. These are his gastric varices. my chance of getting a TIPS in this is very low. This is his portal. And even if I get a TIPS in him, will I be able to reverse the flow? Because the flow is already going away from the TIPS because of his cirrhosis. So we actually did a splenic embo. This was the one I showed you initially, that he had complication of pleural effusion, atelectasis. This was drained, and he did okay. But always realize this is something which can happen. So when you embolize the upper pole, you might be treating the varices, but you will have these complications. So tell them look out for pneumonias, inceptus spirometry, and from there. Any questions?
Good cases, Chaitanya. Wonderful cases. You know,
For that HHT one, I just do the whole spleen.
Why do you always want to left some spleen back, right? Because it has function of protection for the body for infection, right? So we always tend to do partial splenic embolization. Whenever you did the whole spleen, you put into more trouble, right? And he was asymptomatic. Only reason for doing it was to decrease the flow to that hemangioma so that it does not rupture, or he's 21 years old. So these hemangiomas will not rupture on their own. Problem happens when these kids play some sports, they get hurt, and then they have a big time hemorrhage. So it was done as a preventive measure there, rather than actually get him back later. Welcome.